Hello and welcome to the webcast titled, How the Nation's Largest Dental Claims Collection is Transforming the Industry. We have just a few announcements before we begin. The slides will advance automatically throughout the presentation. To enlarge the slides, click the Enlarge Slides link located above your presentation window. Should you need technical assistance, click on the Help link. If your screen freezes or the slides do not appear to be advancing as they should, please try exiting and restarting the session, as it may be an issue with your connectivity. At any time, you can submit a question using the Ask a Question box located in the bottom left-hand corner of your screen. Please note that participants dialed in on the phone will experience a slight delay between the audio and the slides. I will now turn the call over to Robin Gelbert, President, Fair Health. Please go ahead.
Good afternoon. I'm delighted to address you today and update you on the exciting work underway at Fair Health and describe to you how our data assets and tools are supporting a variety of business practices and objectives. The PowerPoint presentation will last approximately 1/2 hour, which will allow the balance of the time for your questions. Before I begin, I want to take a moment to thank Evelyn Ireland, Ruth Ann Woodley, and the NADP for their help in disseminating information about this webinar. They not only broadcast the originally scheduled date, but were helpful in letting NADP members know about the rescheduled date due to Hurricane Sandy. Also, I just wanted to note that the audio for this presentation, as well as the slides themselves, will be made available on our corporate website within the next week or two. As many of you probably know, Fair Health was created as a result of an investigation brought by the New York State Attorney General. The Attorney General was looking into certain practices involving out-of-network reimbursement. In the course of the investigation, the Attorney General determined that there was an impermissible conflict of interest in the way in which out-of-network reimbursement was being calculated. The case was ultimately settled by all of the parties in 2009 for the collective sum of $95 million. The settlement featured certain key elements. First, it provided for the creation of a new, independent, not-for-profit organization. That new entity is Fair Health. We were established in October 2009. Next, it required Fair Health to create a robust database and enhanced data products to make available to the insurance industry in order to further the fair and transparent adjudication of healthcare claims. Third, Fair Health was tasked with creating a free web-based portal which would allow consumers to obtain information about the cost of procedures and services they may access out-of-network in the specific geographic region where the procedures would occur. Finally, we were mandated to develop a research platform to support public policy, health systems, and health economics research. It should be noted that the settlement agreement required that Fair Health integrate the talents and expertise of academic researchers, economists, and statisticians into the development of a new database. Accordingly, we partnered with a talented team of researchers who are known as the Upstate Health Research Network, which is comprised of 8 separate institutions. In addition to working with the UHRN, we work with a national board of scientific leaders, including behavioral economists, healthcare economists, health policy experts, and the like, who further inform the work we do. Finally, one key point should be emphasized. Even though the New York Attorney General was focused on activities within New York State when he launched his investigation into the healthcare industry, the settlement agreement resulted in a national remedy. Fair Health now serves the data, analytic, and educational needs of customers and consumers across the country. So what makes Fair Health and Fair Health data unique? It should be noted that we house the largest and most diverse private claims data collection in the country under the roof of an independent, not-for-profit institution. We have over 70 contributors nationwide who contribute data to our repository, and that number continues to grow as new contributors approach us seeking to be part of our contribution program. The data contributed reflects healthcare for over 129 million lives. Currently, we have north of 15 billion distinct billed procedures in our database for the period 2002 to the present. That number continuously increases as the data gets refreshed and updated on a rolling basis. We employ a robust auditing and validation program to ensure that the data are complete and representative. Let's take a closer look at the database through the lens of dental services. Of the over 70 contributors of data to the database, more than 40 contributors contribute dental data. For each dental module that we release, it captures the prior 12 months of dental services while allowing a 2 to 3 month window for production. So, for example, our last dental release went out in July 2012. That module would reflect data from approximately April 2011 to April 2012, with May and June used to prepare for production. In that last module, there were approximately 140 million billed dental services. As you may know, we offer two lines of products. One we call FH Benchmarks, which are based primarily on actual data. The other line of products we call the FH RV Benchmarks, due to the fact that it incorporates a relative value methodology to populate the various cells. The data are organized into 491 distinct geozips in order to provide a granular window into the data to enable analysis and nimble market use. A geozip tends to track with the first 3 digits of a zip code. Fair Health continues to be served by an independent premier board of directors. I invite you to visit our website and read through their backgrounds and accomplishments. They represent thought leaders in a variety of fields, including insurance, healthcare, academia, law, and consumer advocacy. It should be noted that they serve without compensation and are an extremely engaged and vibrant deliberative body. As we continue to move through many layers of healthcare reform and changing reimbursement models, the board has proven to be an incredible resource. It takes a village to advance fair health initiatives. In addition to the board of directors, we routinely reach out to a number of other experts and stakeholders and engage in an open and rich exchange of ideas and recommendations. We then integrate their input into product development and operational policies. This slide gives you a flavor for the network of advisory boards we work with. As you can see, we have both the Dental Actuarial Group as well as the Dental Advisory Board. With the former, we discuss proposed algorithmic or methodological changes that are being tested or evaluated with respect to the dental module. We use the latter group to discuss broader policy issues bearing on product development or enhancement, QA, and release schedules. We welcome participation on these advisory bodies from our customer base. If you would like to participate in these discussions and do not currently have a representative member on these boards, please reach out to me offline to express any such interest. While the original New York investigation into Ingenix and the resulting settlement largely focused on the adjudication of out-of-network claims, our data products and consumer tools have had a much broader reach. In addition to supporting out-of-network reimbursement, our tools and products have become increasingly valuable to the management of consumer-directed health plans and the sound design of ACOs and bundle payments. Fair Health data also serve as a strategic tool to help inform the negotiation of network panels and an important assist to human resource and health benefits personnel who have begun to see the concrete impact and advantages of shaping a growing generation of informed consumers. Our data and consumer content have also attracted the attention of a number of states as well as the federal government. We have a number of conversations underway with various states about how our data can support their UCR fee schedules, workers' comp and auto liability programs, APCD's anti-fraud efforts, and reform initiatives. In fact, our data is already being currently used to support state dispute resolution programs. We've also had an ongoing dialogue with the federal government about how Fair Health can help inform consumer fact labels, medical reimbursement data centers, and essential benefit design. Because of our independence and not-for-profit status, our data also becomes a valuable source of data to support out-of-network adjudication of dental and medical claims on state exchanges or the federally facilitated exchange. Indeed, we have learned of some states already moving in that direction. Commercial customers have also been intrigued by the ways in which our data can support fraud detection and adjudication dashboards. Our commercial plans and licensees have also been increasingly excited about using our independent, comprehensive data to support cost transparency tools and educational hubs on member or employee-protected websites. Finally, our data supports our research platform, which I will discuss further in a few moments. When we were going through the transition with Ingenix, we did not want to disrupt the marketplace. We recognized that we needed to create a seamless transition in order to allow customers to continue their operations without interruption. So we purposely sought to avoid any changes in file formats or release schedules of the data products. We likewise retained stability with respect to the data contribution program and processes. While we made certain methodological enhancements to the data to fulfill the mandate to create a more robust and transparent database, we treated the first iteration of the database as Fair Health 1.1, incremental but smart change. After spending 2010 readying the database, the website, and our infrastructure, we went live in 2011 with Fair Health 1.1. Now that we've been out in the market for almost 2 years and having heard from customers that a seamless transition was largely achieved, we've moved to the next stage of our development, what we call Fair Health 2.0. Fair Health 2.0 is three-pronged. It consists of a technology component, new product development and enhancement, and an enriched contribution program. Let me discuss each component separately. With respect to the technology component, we have currently operationalized a new state-of-the-art technology environment using an Oracle Exadata platform. This platform allows us to exponentially accelerate processing capabilities so that we can process our billions of claims more quickly and efficiently. It also allows for high-speed automation of a large number of tasks associated with product creation, validation, and contribution. It further allows us to compartmentalize tasks so that we can be doing product creation of the dental module while testing separately a new algorithm on another product or engaging in quality assurance on yet a third module. Significantly, this new platform and software also expedites statistical data pulls and reports made available through our customer service program. Fair Health 2.0 also involves exploring a number of new product features and refinements, including a possible new dental allowed module and or dental hybrid module, which includes both charge and allowed data. Also, Fair Health 2.0 will allow ongoing analysis by academic researchers and statisticians into current algorithms for removing outliers and determining whether there are additional refinements that should be introduced. And finally, let me turn to the changes underway in Fair Health 2.0 with respect to our data contribution program. When we first became operational, we tried to adhere closely to the contribution program then in place. However, with the passage of time and as data customers expressed interest in using the data in a variety of new ways to respond to market changes and reform initiatives, it became clear that the contribution fields identified previously by Ingenix were not optimal to meet current customer demand and need for new analytics and products. For example, currently the contribution program lists age and gender as an optional rather than a mandatory field. However, with the new infusion of dental enrollees under the Affordable Care Act, it will be helpful for customers to analyze data based on age and gender to help support benefit design and other strategic decisions. Also, if we had an encrypted patient identifier, we could track care in a fashion that helps bridge quality and cost analyses. Similarly, if we had allowed data, we could use that field to further vector the bill charge to ensure we were receiving the non-discounted fee-for-service rather than the allowed charge. We recognize that added data is valuable, so we have a number of incentives for the additional fields. We can discuss those incentives in greater detail offline. Let's talk a bit about the consumer website. As you know, creating a free consumer website that provided cost information based on the relevant geographic area was built into the DNA of the settlement agreement. To help consumers understand the cost information we were providing, we offered an educational platform consisting of an original innovative curriculum we called Reimbursement 101. That curriculum offers consumers a variety of chapters or segments dedicated to insurance-related themes and concepts, some of which pertain specifically to dental insurance, some to medical insurance, and some are relevant to both. We also created a dental glossary of clinical and insurance terms, as well as a listing of helpful consumer resources. We continue to add new tools and functionality on both the medical and dental sites. For example, we recently added a feature called the FH Dental Estimate Assist, which I'll discuss in a moment. We are also excited about offering a Spanish translation of our educational content on the site, which just went live 2 weeks ago. We have already had discussions with the ADA and are excited about integrating their new translation of CDT codes into the site. We hope to license that new translation and offer it in 2013. We are also working on a mobile app for the consumer website, which should also be ready in the first half of 2013. The Dental Estimate Assist was launched on August 25th. It mirrors in principle what we introduced on the medical cost lookup. While the cost lookup tool is generally based on individual CPT or CDT codes, we try to advance the consumer search by allowing them to populate their virtual shopping cart with related procedures. For example, on the Medical Estimate Assist, if a person were looking to search for costs associated with a colonoscopy, the FH Medical Estimate Assist would allow a consumer to also see the estimated costs associated with a potential biopsy and with the anesthesia associated with the procedure. The Dental Estimate Assist, which was created with the assistance of our dental director, Alan Vogel, as well as with the input from our Dental Advisory Board, offers related procedures for a number of services, including a root canal or wisdom tooth extraction or emergency visit. We've received extremely positive feedback from consumers about this tool, which has allowed them to plan more responsibly for the costs associated with their various dental visits. In the next few moments, I'll share some screenshots that demonstrate this functionality. Here's a screenshot from our Reimbursement 101 curriculum so you can get a flavor for the types of segments we offer. The left side of the screen lists a sampling of the other topics we offer. As you can see, we use plain language, engaging original graphics, and on a number of segments, accompanying videos that bring life to the content. Here's a screenshot of the dental glossary we offer that includes easy-to-understand descriptions of the terms we use in our dental taxonomy that dovetail with CDT language employed by the ADA. The glossary also offers easy-to-understand definitions of common insurance terms like annual maximum. The educational foundation we offer through the Reimbursement 101 series and our glossary has added greatly to consumer understanding of reimbursement principles and personal responsibility for cost sharing. That, in effect, becomes a win-win for the consumer, employer, and plan. This tangible value afforded by the site was recently noted by the White House. We were singled out and honored at the White House Summit on Smart Disclosure held this past spring. Our cost lookup tool was held out as an example of providing smart, actionable tools for consumer decision-making. Interestingly, more consumers come to our site for the dental cost lookup tool than the medical tool, which in many respects comes as no surprise. The higher number of dental searches reflects the higher percentage of out-of-network dental services as compared to medical services. The higher dental-related utilization of the website also reflects the high amount of cost sharing that factors into many dental plans. For those of you who have not had the opportunity to go to our consumer website, this reflects the landing page. As you can see, there are two separate pathways for the dental and medical cost lookup tools. As noted, more consumers are entering through the dental portal. We thought it would be helpful to walk you through a sample search. If a consumer did choose the dental portal, they would then be taken to this landing page. To begin their search, a consumer would be required to enter the city or zip code where they intended to seek dental services. As noted, our data is separated into 491 geozips to provide greater precision to the cost information provided. The consumer would also be asked to indicate whether they are insured or uninsured. If the latter, we would skip them to a results page that does not address insurance reimbursement considerations, but rather a page that simply provides the full estimated costs for the procedure selected. Finally, the consumer would be asked to either note the CDT code of the procedure sought or use our easy-to-navigate taxonomy to select a procedure. Let's assume the consumer is searching for information regarding a wisdom tooth extraction in the Hartford area. The consumer would next be taken to this results page. Let's walk through the information provided. Working from the left, we provide the official CDT code for the procedure. Underneath the CDT code, you see a yellow plus symbol. Excuse me. That signifies that this procedure has been coupled with our dental estimate assist tool, which we can demo in a moment. The next column incorporates the official ADA nomenclature. The next column has more consumer-friendly terms, and the next column shows the estimated charge at the 80th percentile. That is based on our repository, 80% of doctors charge this amount or less. The next column reflects the class of service for the procedure. That is whether the service is typically considered preventive, basic, or major. This procedure is typically considered major. In instances where the procedure may be considered a different class depending on the plan, we allow the consumer to toggle between the classes. The next column shows the estimated level of reimbursement, which we estimate to be 50% of the estimated charge. We default to 50% of the estimated charge for major procedures, 80% of the estimated charge for basic services, and 100% of the estimated charge for preventive services. However, even though we offer a default for the percentile and percentages, we offer separate calculator functions that allow consumers to change the amount of the percentage or percentile depending on the features of their plan. This customization was actually one of the reasons leading to the White House honor we received for the website. So based on this information, the site tells the consumer that for this procedure, the consumer would be expected to pay approximately $262 out of pocket for this specific service. Now let's see how the dental estimate assist works. If the consumer had chosen extraction of a wisdom tooth and had clicked on the yellow plus sign on the earlier page, they would be prompted with these additional procedures that are related to an extraction, allowing them to populate their virtual shopping cart with additional items. Had the consumer selected these 3 additional related procedures, their results page would automatically recalculate and come up with this increased charge of $612.50. Consumers are finding this very helpful to gain exposure to these added costs in order to avoid unpleasant surprises upon the receipt of the bill. As mentioned earlier, providing free cost estimation tools to consumers was built into the DNA of the settlement agreement when we were established. It has been striking to see how these cost transparency and educational tools have become the object of interest for many of our commercial customers. Given the rising tide of consumerism and transparency, our data licensees are beginning to express keen interest in using these tools on member-protected websites. That is, they're branding these tools for their members or their employees through a white label or API functionality for a specific fee. Alternatively, some organizations have expressed interest in hyperlinking to our consumer tools from their sites, which we are happy to permit at no cost. Customers are finding that the website's transparency tools and content constitute a value add for employee or subscriber relations. They're finding that the tools and resources give rise to reduced costs for out-of-network services as employees learn in real time their potential exposure for such services and make choices to stay in network. The tools and resources also result in reduced costs for customer service and HR services, as consumers become empowered with information they would otherwise seek from customer service representatives and HR personnel. Customers also find that making these tools available gives rise to greater overall employee and member satisfaction. To support the strategic and business needs of our customers, we also offer customized cuts of data that aggregate certain data fields that broaden the elements and time frame otherwise available through our dental modules. For example, a data customer might be interested in a longer time frame than 12 months that's captured in a module in order to identify trends. In support of this service, we have data from 2002 to the present. We can also provide a window into the frequency of certain procedures as well as the age and gender breakout for specific procedures in specific geozips. We can also recalculate the data using a statewide geographic region versus a single geozip or cluster data into rural and urban regions. To give you a flavor for the types of inquiries that might be supported by our data, we thought it would be helpful to provide two concrete examples. Obviously, the types of inquiries that could be posed using the data are limitless. One valuable study might involve obtaining a window into the utilization of fluoride treatments for high-risk patients. For example, an organization might be interested in comparing the use of topical fluoride treatments in different geographic regions to help inform cost analyses and benefit design studies. Similarly, an organization might have an interest in comparing utilization results for amalgam versus composite fillings for posterior teeth to help support a number of internal business decisions. Here's a bar graph that represents one of the many ways in which data can be presented visually. We also create box plots and histograms and a variety of other visual windows into the billions of data points in the repository. For illustrative purposes, we compared 5 different geozips in each of 3 states, New York, Missouri, and California. As you can see, there is wide variation in the outcomes, which spark a number of policy and business questions. For example, this graph might cause one to ask, why is there such a variation in fluoride use within individual states? Why is use low in areas expected to have more high-risk patients? Are these results consistent with the ratio of patients typically considered as high risk for cavities? Could insurance coverage be influencing utilization? Are plans appropriately priced for these levels of coverage and utilization? This next slide reveals the findings of the study we did involving composite fillings using, again, 3 states, New York, Missouri, and California. In effect, we looked at the percentage of composite fillings as compared to all reported fillings on back teeth. Again, as demonstrated, the data reveals some significant differences within the same state, triggering a variety of questions. For example, in looking at this data, one might ask whether risk-based care will drive higher usage of amalgams. Are there regional differences in utilization that should be considered when pricing benefits for children under the exchanges? Can the differences illustrated be related to urban versus rural populations? Are the differences related to gender? Is there a desired behavior that could be incentivized through coverage provisions and/or limits? Are current coverage levels appropriate? As most of you know, amalgam fillings typically have a longer survival rate on multi-surface than multi-surface fillings, and composite fillings may be preferred by patients for aesthetic reasons or dental practice choice. Hopefully those 2 examples give you a flavor for the power of data. In the wake of the recent election, as efforts to implement the Affordable Care Act increase and other private efforts to reform the healthcare industry continue, data becomes a powerful strategic tool. Data can help you evaluate your performance over time or help you evaluate your performance as measured against other geographic regions. Data can help you identify unintended consequences of legislative or regulatory provisions impacting the industry, and once identified, help you formulate position or policy papers highlighting such consequences to obtain relief. Data can also help you identify emerging clinical trends that allow you to engage in creative and strategic benefit and provide a network design. Data can help you implement sound, fair, transparent reimbursement practices to help avoid challenge, dispute, and confusion. Indeed, the benefits and utility of data are endless. At this time, I'd like to thank you for participating in the webinar and allowing us the opportunity to share our unique story with you.